Hi, I'm Dr. Minerva Santos, and welcome to Your Health Today, a TV show that tries to keep you up to date on the medical information today. My guest is Dr. Ingrid Dziedzic, who is an ophthalmologist here in the Mount Kisco, Yorktown area for a very long time, and who's an amazing surgeon. So, thank you.
Thank you for having me.
Now, she's going to be talking about a very interesting procedure, which is CK, and basically which allows you to read without using reading glasses, which, as us baby boomers know, our arms are suddenly not long enough for us to be able to read. And I don't know about you, but I've had to succumb to using reading glasses. So, tell me about this procedure, which I'm thinking about.
Well, Minnie, I want to talk about CK because our audience probably knows a lot about LASIK.
Yes, I had LASIK in one eye, which now I still need reading glasses for this eye. The LASIK's kind of wore off because it was a while ago.
Exactly, that is what happens. People usually get LASIK in their 20s, 30s, perhaps 40s, but thereafter, the change that takes place is a natural change where our accommodation decreases, and then you need another solution. You could do repeat LASIK, or perhaps PRK. The audience might not know PRK as much as they do LASIK, but it essentially is the same technology. We use the same type of laser, but there is no cutting. There is no creation of a flap. Mm-hmm. I consider it a safer alternative to LASIK, and I prefer it. But like you, I myself had LASIK about 9 years ago, mm-hmm. and it was great initially. And then came that strange time, where the focus was going in and out, and in a lot of light you could manage to read. But it was no longer easy. So, there are many reasons why people should know about CK. The main one is that it's simple and non-invasive. As opposed to laser procedures like LASIK and PRK, there is no removal of tissue. You have everything you had before the procedure at the end of the procedure, only it is reshaped. It is done in an office, takes approximately 2 minutes, and at the end of the procedure, you can read the menu without glasses.
Now, how does it work? Tell me what is the procedure, because I'm not familiar with it either.
Exactly. And you know what I think happened is CK came out when the economy turned downward, and it's not an insurance-covered procedure. Mm-hmm. And
but neither is LASIK.
Yes, but LASIK came out when the economy was good.
It was better. People would put money away for it. Yes.
And even LASIK suffered. The number of cases dropped drastically, and so a new procedure in that realm had a very hard time to let itself be known and to penetrate the market. I found out about CK at one of the academy meetings of ophthalmology, or perhaps Ophthalmology Times conference in New York City, and I found it very attractive to me personally. So I flew out to Kansas City to have a colleague of mine perform this procedure on me. Mm. And it was done on a snowy November day, and I brought my secretary with me because I wasn't sure how I would be after the procedure, and we had the rental car and all that. Well, the procedure was totally painless. It was quick, and I felt fine, so fine that we went shopping, and I spent too much money afterwards.
That was the anesthetic.
Yes. But then we went to a restaurant in that shopping area to have dinner. We sat by a fireplace. It was a very romantic restaurant and very dim. And my secretary said, "Oh my God, I forgot my reading glasses." And I said, "Well, let me try." And this was approximately 2 hours after the procedure. And I read to her in candlelight the menu. That's how wonderful that was. And then we flew back in 2 days back home here, and I was able to read on the airplane without having to dig through my purse and find the glasses and so forth. And I decided on the time as I was flying home that I will purchase that machine and learn how to do it. And that's been now 5 years ago, perhaps 6. And I love it.
Now, what actually do you do?
You evaluate the patient as you normally would, comprehensive evaluation, including topography, corneal thickness. You evaluate their dominance. People know that they have a dominant hand, the hand they write with. They may not know, but they also have a dominant eye. So it's usually helpful to determine which eye is dominant. In 90% of cases, it's same as the hand dominance. But here and there are crossovers. So we have little fun tests in the office to determine which eye is dominant. For anybody sitting at home, if you were to pretend to hold a gun, where would you put it to try and fake it as aiming? That's your dominant eye.
Okay.
The one you close while you're doing that is your other eye, which you would use for reading, whereas you would use your dominant eye for distance and allow your brain to fuse the two images into one. It's called blended vision, or used to be called monovision.
Right.
Blended vision is an almost better term when you speak of CK, because the sides of the corneal curvature created by CK are able to fuse in the mid-range of vision, giving you much more of a really blended vision, sort of like in a progressive multifocal glasses. What CK does is changes the curvature, steepens the curvature of the cornea, and achieves that by applying ring of treatments at differing distance from the center of vision. The further to periphery you go, the less effect it has on the power change. So we can apply a ring at 6 millimeters, 7 millimeters, or 8 millimeters away from the center of cornea, or optical center really. And we measure. We have a little instrument that allows us to measure and gives us a path to follow when we do the treatment. The treatment consists of using a handheld device that enters cornea but doesn't penetrate it. It enters it and penetrates it, but not totally. It doesn't cut through it.
Right.
It goes in a pre-measured depth, and then through pulsing, basically alters the collagen structure in that spot. And as you do a ring of 8 spots, you create a zone, a ring of tightening. And as a result, the central portion pops up, becomes steeper.
Right.
And that creates an add of +1, +2, +3. The maximum I've done is add of +4.5 diopters. And that corresponds to what you see in the store when you buy reading glasses. You know, these, they come pre-measured usually in...
Right, by 5s.
Exactly. So, and they usually are hard to find above +3. With CK, it's rare to go above +3 also, but we can go to +450. And in addition, we can correct astigmatism by strategically applying treatment only along the flattest axis of the cornea, thus bringing it to equal position with the steeper axis, making astigmatism less or none at all. And we can correct small amounts of distance hyperopia, which is farsightedness. Maybe in a patient who wears bifocals with a +150 for distance and +3 for near, we can correct the dominant eye for the +150, and we can correct the other eye for +3, and they wouldn't need glasses most of the time. I always tell my patients that there are occasions where the print is very small, usually on medicine bottles and disclaimers on advertisements. You may need to put a +1 pair of pre-made glasses, but that's about it. Most of the time you won't need it.
Right, but that happens with LASIK. When I had the LASIK surgery, it was great for distance, but I found that I still needed glasses to read, because even though theoretically my brain was supposed to accommodate and I should be able to read, the eye that I had the LASIK on would hurt, and I needed the reading, because no matter how I tried, I could not get this eye to read and pick up. It still appeared blurry to me, and it would fatigue, so I needed reading glasses. So,
and that is a little disappointing after a procedure.
Yes. But the distance part was great, because I didn't need my glasses for distance, which is why I got it, because I couldn't watch TV. If I woke up in the morning, I couldn't see the clock.
Sure, exactly.
So for me, the LASIKs in the one eye was great, because I was able to see distance, and I was able to drive without glasses. But the reading part, which is something that I do a lot of, that became like, all right, so I ended up having to use reading glasses.
Well, this is why I would recommend CK, because you really do not want to get into repeat laser procedures.
Oh, I'm not gonna. Yeah, I wouldn't.
Because your cornea can
done.
get too thin, and you can be in real trouble. So my philosophy is usually the least invasive, the better. And certainly in order of invasiveness and risk, CK is the least, PRK is in between, and LASIK is the most.
Right. Especially when they have you sign the consent that says, you could go blind.
Yes, exactly. Exactly.
Now, are there any contraindications or any people that should not have CK?
Conductive keratoplasty really does not have medical contraindications, but there could be kind of neurologic, psychologic contraindications. There are patients who are very specific and do not adjust to new situations well. There are patients whose fluidity to accept something new and different is just not very developed. And this is where a lot of time is spent with the patient to evaluate, are they a good candidate? Will they be happy? We always speak in ophthalmology about not just 20/20 patient, but 20/20 happy patient. Because you could have a fantastic surgical result and a very miserable patient and a bad outcome on the whole in terms of relationship of patient-doctor. So.
Right. So now, if the patient has dry eyes, if they have any autoimmune disorder, bleeding disorder, none of that comes into play. That's interesting.
None of that comes into play.
Yeah, it's truly so non-invasive that none of that comes into play.
No. The only precaution I would take is if somebody has history of recurrent ocular herpes, I would...
Okay.
Any procedure that you do to an eye like that could wake it up.
Right.
So I would pre-treat with...
You pre-medicate?
Exactly.
Okay,
exactly.
That's interesting. Now, what age, I guess any age, if you have even a teenager?
Yes, as a matter of fact, I think the youngest patient I treated, she wasn't a teenager, she was maybe 24. And in one eye, her vision was perfect. And in the other eye, she had 4 diopters of astigmatism. And she wasn't a good contact lens wearer, but nobody is really with the 4 diopters of astigmatism. It is hard to be well fitted and happy. And usually one-eyed contact lens fittings are not so easily adjusted to, because one eye feels naked compared to the other one that has the contact lens. So I treated her about